Friends, for the past 2 days in this meeting, we have been trying to crack the calcium in the coronary arteries. And as you know, there are several tools which are available now to treat the calcification in the coronaries. And amongst these tools, IVL has emerged as one of the important competitors. So, since it is easy to use, since the results are, I would say, reasonably predictable, there is a big jump in the use of IVL. So that brings a very important question to me.
Recording in progress.
A very important question for me in my mind is that can IVL be a replacement for ROTA ablation in these severely calcified and diffusely diseased coronary arteries? Well, you all have seen that calcification of the coronary artery is one of the biggest enemies for the implantation of the stents, because it leads to inadequate delivery of the stents, inadequate expansion of the stents, and also promotes high incidence of late stent thrombosis. Several tools are available, and amongst these, the two which are most popular and are very useful are rotational atherectomy and of course cutting balloon, not as effective as rotational atherectomy for calcific coronary artery disease, particularly diffuse disease. But of late we have now got the shock wave or the intravascular lithotripsy. Now there is no doubt that lithotripsy has certain advantages which we have all seen over the past few years ever since it has been introduced. It is a balloon based therapies, and the shockwave IVL system is easy to learn compared to the other forms of therapy, particularly ROTA ablation. But what I am going to show you is some of the limitations of IVL, and then some situations or a lot of situations where IVL would not have worked. Let me go a little bit fast here. First thing is IVL can only be used in lesions which are uncrossable with balloon. Can't be used in lesions which are uncrossable with balloon. So you have to first cross the lesion, and then the IVL balloon would go. Otherwise, it generally does not go. It's a difficult device to deliver because of bulky nature of the IVL balloon, and is generally recommended for deep calcification. But many of the patients have got only a superficial calcification and may not be required. And lastly, high cost as compared to even ROTA ablation. Now let us look at some of the studies conducted with the IVL. If you look at Disrupt-3 trial, which included 431 patients, crossing failure with IVL balloon was encountered in 2% of the patients. And in 17% of the patients, they had to use a guide extension to get the IVL balloon across the stenosis, and a buddy wire was used in almost about 3% of the patients. So overall, you can see that almost about 15 to 20% of the patients, you would not be able to place the IVL balloon directly into the target site. Then adjunctive devices, for example, balloon dilatation is required before you can put IVL balloon in almost half of the cases. Otherwise, the balloon of IVL would not be able to reach at the target site. And ROTA ablation was required in this study in almost 5% of the patients. Then comes the procedural portions of this study. IVL catheter per patient required was 1.2, which adds to the cost. And the outcome in Disrupt-3 trial, MACE at 30 days was 7.8%. It's not a small MACE at 30 days. And deaths occurred, of course, in 0.5% of patients, and serious angiographic complications in almost about 2.5% of the patients. So it is a procedure which is not totally safe. It has got its own inherent limitations. It has got its own complications. Now I'll show you some cases where you would be alarmed that can we use IVL in such cases. Let me first define what is a diffuse coronary artery disease, what is a tortuosity, what is calcification. Now you can see an example here. This is a diffuse coronary artery disease which is highly calcified. Now, if you go to the literature, there is no set definition given by any of the societies what is a diffuse coronary artery disease. But what I feel is that anything which is longer than 25 millimeter in length, I call it as a diffuse coronary artery disease. And tortuosity, when there are multiple bends before, within or after the disease segments, it's a tortuous coronary artery. And calcification, as you know, can be classified as mild, moderate, or severe even on fluoroscopy. So this is one of the patients which has got a high-grade calcific stenosis, which is in a diffusely diseased arteries. Now, in my experience, I have done almost about more than 1500 ROTAs, and diffusely diseased arteries have been done in 39 patients with a success rate of 100%. And we had only one death. This was because of slow flow. Now I'll show you one of these cases, and this is the case which I just now showed. This is, you can see a very high grade stenosis in the left main distal. The LAD is highly tortuous, calcified with a lot of bends, circumflex, obtuse marginal, all are diseased. And this patient had carcinoma of the glottis. The surgeons had refused surgery on him. He presented to us with acute left ventricular failure. We treated his failure, stabilized him, and this was the angiogram after 4 days. Now, can you use devices like IVL or any other devices that I have enlisted here to treat these coronaries? Certainly no. So, we embarked upon ROTA ablation with some fear in our mind of slow flow. So, we used a step burr approach of 1.25 followed by 1.5 mm burr. And following this, we put two long stents, 38 mm distally in the LAD. And then we did a left main bifurcation angioplasty using mini crush technique. On one hand, we had a LAD stent, and the other is the LCX stent, and a mini crush technique was used. And this is the final result after putting in 4 DES. So very gratifying result, and it was impossible to achieve this result with IVL. Now this is a second patient, 87 years old lady, and you see the right coronary artery. Now this is a Shepherd Crook right coronary artery with multiple bends, highly tortuous vessel, very old lady, diabetic, and you see distal RCA bifurcation stenosis. So again, right from the beginning, we took a Amplas guiding catheter, threaded the vessel with a ROTA wire, and straight away went with the ROTA using a 1.25 mm burr. And after that, we started deploying the stents after, of course, post ROTA balloon dilatation. And we deployed 4 stents, first distal into the PLV and distal RCA, then into the mid RCA. And then the third stent was deployed into the PD using a tap technique. And finally, a stent at the proximal, osteoproximal part of the right coronary artery. And this was the final result. Now again, these kind of cases cannot be done with the IVL. The third patient is again a patient who had significant diffuse disease, high-grade stenotic lesions in the LAD, which is highly calcified. So this was the IVUS which we did, and you can see that there are areas where there is a 360-degree calcification with a thick layer of calcium, both superficial and deep. And so we had to resort to ROTA in this patient, 1.25 followed by 1.5 mm burr. And after ROTA ablation and putting in 3 stents in the LAD, this was the result. Excellent result, which again is not possible with devices like IVL. The next is a 78 years gentleman who is having a chronic kidney disease. He was on dialysis, and ejection fraction was 40%. And you see here, this is the pre-PCI angiogram. You can see that again a very thin diffusely diseased LAD. It's not a very large size vessel. The vessel is heavily calcified with areas of high grade stenosis in between. LCX is also highly calcified with moderate degree of stenosis. So we first did a IVUS of the LAD in this patient, and you can see that there are 360-degree rims of calcium in the proximal LAD, mid LAD. So how far you can keep on putting IVL balloon? These balloons would not even go. So we embarked upon ROTA, and this is a ROTA using a 1.5 mm burr straight away. And following this ROTA, and this was the result after putting in 2 long DES, 38 into the LAD. Thereafter, we went into the circumflex, and the same burr, 1.5 mm we rotated into the circumflex. There was quite a bit of difficulty in crossing that high-grade stenosis in the circumflex. You can see here, the burr is getting stuck over there. Finally, we were able to get this burr across this, and we removed the calcium, prepared the bed for implantation of a long stent. So we had to implant 2 stents, 2.75 into 48 from ostium to proximal part, and then distally another 14 millimeter stent. And so this is the final result in both the vessels. So lastly, this is another case. Now all these cases I am trying to show you and convince you that the technology of ROTA is the only technology which would have worked in these cases. Where is this gone? Can you come? Can you come here? I can't see the cursor. Cursor has got display somewhere. Yeah. No, remove the other one also. Yeah. So this is a pre-PCI angiogram, again the similar kind of LAD, and a RCA, again diffuse disease. And this patient had a diagonal which was seen in the previous angiogram, and the LAD was in fact a CTO. So we crossed the CTO, and then you see that the kind of vessel that we found after crossing the CTO, diffuse disease vessel right from proximal part to mid part and distal part. So this is after doing balloon dilatation of the LAD, and we did a IVUS in this LAD, and we found again severe calcification. And then we did ROTA using step burr technique, 1.25 followed by 1.5 millimeter burr. And then after putting in 2 or 3 stents, you can see that the proximal to mid part of the LAD looks excellent. Now this is a RCA of a patient which was a challenge for me, a case which I did live in one of the meetings outside India. You can see here that the right coronary artery has got a high-grade stenosis, both proximal going up to the mid, and then other stenosis in the distal part. And even the ROTA burr would not go. We used a Judkins guiding catheter. Firstly, the wire was difficult to get into the across the stenosis, but with a slow speed rotation, we could advance the wire gradually, and then the next problem was that we were unable to cross this stenotic lesion with burr of 1.25 millimeter. So at that time we got frustrated. We used the Amplas guiding catheter, but you can see that there was a bend in the Amplas guiding catheter, and this bend would not allow the burr to go in. So I had to burr at a very high speed to get across this bend, and finally the burr went in, and then it started burring the lesion, and we were able to get across. So we did a ROTA of the proximal to mid part of the RCA, and then deployed stents. And after this, we in fact doing a ROTA of the proximal to mid part, we pulled out everything. We thought we will be able to do the distal part just with the balloon, but that was not to be so, because balloon would not cross. So we had to go back to Judkins now, and now we again had to rewire with the ROTA wire, and then did a ROTA into the distal part and deployed 3 long stents, and this was the final result. So friends, in the last, ROTA is the only modality which worked in such a calcified and diffuse coronary artery. But I think more important than that is ROTA works where IVL has failed, and I will show you a case where even ROTA had failed, then we use a IVL, even IVL failed, and then we have to fall back onto ROTA, and that worked. This is the case. I will quickly run through it. High-grade stenotic lesions in the proximal to mid to almost distal part of the LAD with very tight stenotic areas at 2 sides, proximal and at the point where the diagonal is coming. And see the IVUS images, highly calcified rings of calcium with a calcium score of 3. We did a ROTA using a 1.5 millimeter burr, and following this you see that we inflated balloons. There was big waste, particularly in the proximal part. So we then use a IVL balloon. The distal lesion opened up reasonably well, but see the proximal lesion, you can still see a lot of waste on the proximal side. So this is a post IVL post balloon result. You can see the waste continues to remain, particularly in the proximal lesion. So then we use a high pressure balloon in this case, but even the high pressure balloon would not allow the waste to disappear. You can see it continues. So at that point of time we got frustrated. So we then use upsize the burr from 1.75 to straight away 2 millimeter burr. And then we burred this with a 2 millimeter burr, and following that we then put a high pressure balloon and with 3 wires in. You can see that there are 2 buddy wires. We put a balloon and then deployed a stent, and this was the final result after deploying the stent. So friends, in conclusion, I would say that it's feasible and safe to perform PCI in these highly calcified coronary arteries after adequate plaque modification. IVL is, although a easy to use technology, but has several limitations, particularly its inability to advance bulky balloon across tight stenosis. IVL's guided imaging is of course useful, and debulking using ROTA ablation can be performed successfully even after failed IVL using appropriate size of the burr. Point that needs to be emphasized is that many of us are scared in upsizing our burr. We used to do in the previous institution burrs as big as 2.25 and even 2.5. But since they stopped supplying burrs of above 1.75, so in between we were not using those burrs, but we have now got back with almost 2.15 and 2.25. So we upsize the burr. So what is the take-home message? IVL is not an alternative to ROTA ablation, particularly in diffusely diseased and calcified coronary arteries, but may be a companion to ROTA in deep calcification which are undilatable even with ROTA ablation. With that, I thank you very much.